Hello, and welcome to the Clinical Care Options Oncology Podcast. I'm your host, Tim Quill. Today's episode features Dr. Julie Vose from the University of Nebraska Medical Center and Dr. Matthew Davids from the Dana-Farber Cancer Institute. They will be discussing their choices of several recent notable studies presented at the recent 2022 Pan Pacific Lymphoma Conference on the use of BTK inhibitors in CLL and mantle cell lymphoma and the associated potential clinical implications. This episode is part of a larger educational program titled A Global Perspective on Emerging BTK Inhibitor Therapy Data for Relapsed Refractory CLL and MCL in 2022. For more information on the experts, along with a link to the complete program, including a downloadable slide set and expert commentaries, please visit the show notes for this episode. Now let's get started and hear what the experts have to say.
Good afternoon. I'm Dr. Julie Vose from the University of Nebraska Medical Center, and I'm here today with Dr. Matthew Davids from Dana-Farber Cancer Institute. We're going to be discussing some abstracts that were at the Pan Pacific Lymphoma Conference undergoing evaluations of CLL and mantle cell lymphoma therapy. So I'm going to turn it over to Dr. Davids to first talk about some of the CLL abstracts, and we'll discuss them.
Great. Thanks so much, Dr. Vose. So we thought we could get started with the phase 1/2 BRUIN study, which was summarized at the Pan Pacific meeting. And just as a reminder to folks, this is the phase 1/2 study of pirtobrutinib, formerly known as LOXO 305. This is a highly specific BTK inhibitor that is a non-covalent BTK inhibitor. So it's different from the first generation of covalent BTK inhibitors that are already approved in CLL and MCL. And so we saw data on the entire 618 patient phase 1/2 study here at Pan Pacific. And I'm going to talk a little bit about the CLL patients, and then later Dr. Vose will talk about the MCL patients. So in the CLL setting, these were generally patients who had previously received a covalent BTK inhibitor, and there were about 260 patients that were evaluated. It's a pretty representative group of previously treated CLL patients, median age is around 69, and nearly all the patients had had a prior BTK inhibitor. Many of the patients, at least close to half, had also had chemoimmunotherapy. And there were actually some patients in this cohort as well, about 20% or so, who had prior BTK and the BCL2 inhibitor venetoclax, so-called double refractory population. And certainly this was a population also enriched for high-risk genetic disease markers like deletion 17p or TP53 mutation, which was seen in over a third of patients. So certainly a very impressive response in this study. The overall response rate in this population is 68%, which I think is pretty remarkable considering there really isn't a standard of care approach for these patients. And in the poster, there was a really impressive waterfall plot that really made the point that whether patients had discontinued previously on their other BTK inhibitor due to progression or toxicity, they had an equal response to pirtobrutinib. And really across different risk groups, that was also observed. Particularly, I think, which was interesting is that patients who have the classic resistance mutation, the BTK C481S, responded equally well to pirtobrutinib as compared to patients who did not. So this drug really has potential in either group of patients. And then the last thing I would say about this study really is that the safety profile of pirtobrutinib looks very good, and certainly eager to get Dr. Vose's perspective on this as well in MCL. But in the CLL patients, this was a well-tolerated drug. We did see some of the typical BTK inhibitor-related toxicities like bruising, but typically low grade, very low rates of more major bleeding, and really just background incidents of atrial fibrillation and hypertension. So very clean drug. There were no DLTs in this BRUIN study. They didn't reach an MTD, so they selected 200 milligrams as the go-forward dose. And I think it's exciting as we think about where the relapse CLL field is heading to know that there are phase 3 studies now launching with pirtobrutinib compared to standards of care. And hopefully this will lead to an FDA approval for pirtobrutinib eventually in relapsed and refractory CLL.
Yeah, I think that this is a very interesting study, and I'll go over the mantle cell part a little bit later. But I guess the biggest question is, since the toxicity looks pretty good and the efficacy looks pretty good, where do you think this will set in the future? Let's say just pretending the future phase 3 trial, it looks similar to the current ones, but in addition has that ability to overcome some of the resistance issues. Where do you think this is going to sit in the future as far as therapy for our CLL patients?
Yeah, I think that's really a crucial question, and they are also launching registrational trials for pirtobrutinib in the frontline setting. So these studies, fortunately, will take a long time because CLL patients will do well for a long time. I think it is going to be difficult to supplant the covalent BTK inhibitors. We certainly know right now that the sequence of starting with covalent BTKI and then moving to pirtobrutinib is successful, but it's going to take several years before we have the opposite order, where we start with pirtobrutinib, and then we need to know whether covalent BTK inhibitors can be effective subsequently. It does seem like from some early reports now that there is a different pattern of resistance mutations arising with the non-covalent inhibitors, and whether or not the covalent BTK inhibitors can overcome that remains an open question. But I think to your point, because the toxicity profile of pirtobrutinib does look so good, if that really holds up in the phase 3 experience, it could really be a best-in-class molecule and used in the frontline setting based on the safety and efficacy profile.
Yeah, I think that's going to be the question, and it is going to take quite a bit of time to get to that answer, unfortunately. But very impressive data, and I'll go over the mantle cell data a little bit later. Let's move on to the SEQUOIA study and what your thoughts are on that study.
Yeah, so just as a reminder, SEQUOIA is a phase 3 study of zanubrutinib, which is another covalent BTK inhibitor being developed, not yet approved in CLL. But SEQUOIA was really the registrational trial that read out earlier this year and was presented at the Pan Pacific meeting, and actually right around the same time was just published in Lancet Oncology. And so this was a bit of a complex study. There were multiple different cohorts, but really the one that I think is going to be most impactful is cohort 1. Because this is the registrational cohort where patients were randomized to continuous zanubrutinib or a standard 6-month course of bendamustine and rituximab. And this, again, was kind of an older CLL population, so reasonably representative, median age of around 70, included a variety of different risk markers. This first cohort actually excluded the high-risk patients with deletion 17p. And the data look very good for zanubrutinib so far at 24 months. It's a relatively early look for a frontline CLL study, but nonetheless, at 24 months, there was an 85% progression-free survival rate with zanubrutinib compared to about 70% with BR. And this benefit was observed really across different risk groups based on genetics and various clinical characteristics. The one group where there was not yet a significant improvement in PFS was patients with mutated IGHV CLL, where there was a numerical advantage, but not yet statistically significant for zanubrutinib. That's really to be expected with short follow-up. Those mutated IGHV patients can do well with BR. But really, I think the data here are helpful to see zanubrutinib in a larger phase 3 setting. I think the safety profile continues to look very good for this drug. Very few patients had to discontinue zanubrutinib due to toxicity. There are some risks around neutropenia and hypertension with this drug. But one of the things that was very striking to me about the AE data from SEQUOIA here was in a randomized comparison of zanubrutinib and BR, the rates of AFib were actually equivalent between those two arms in the range of about 3%. And that has not been observed with the other BTK inhibitors, including ibrutinib or acalabrutinib, where in these randomized comparisons with chemoimmunotherapy, we typically would see a higher rate of AFib. So again, follow-up relatively short here. It'll be interesting to see if any differences emerge over time, but very encouraging from a safety perspective. And then, the last thing that I'll mention just is, the high-risk patients were studied in separate cohorts in the zanubrutinib SEQUOIA study. They were just given zanubrutinib monotherapy, and then a newer cohort comparing zanubrutinib plus venetoclax. And those both also look very good. It's actually pretty remarkable that the cohort 2 is the largest cohort of frontline CLL patients ever treated with deletion 17p in a clinical trial, 110 patients. And so far, there's been very few progression events now with actually 30 months of follow-up. So certainly need to see how that bears out over time, but very promising data set from zanubrutinib.
Yeah, I've certainly been very impressed with zanubrutinib as far as the toxicity profile, again, being very, very manageable for patients. In particular, patients who've already failed other BTK inhibitors, they can tell a big difference when they go on that. But I think, again, more to come, but as more and more information comes out, it seems very impressive.
Yeah, I agree. I think a question is going to come up, of course, of, how are we going to use zanubrutinib in CLL once it is FDA approved? We'll have 3 great options in the frontline setting: ibrutinib, acalabrutinib, and zanubrutinib. These will also be options in the relapse setting. And, I think bottom line is it's good for patients to have choices. All of these drugs have somewhat different side effect profiles. And so, I think we'll probably be using all 3 of them in clinical practice.
Yeah, that's a good point. So, what particular patient profile would you try to kind of shy away from ibrutinib and go toward some of these newer BTK inhibitors, do you think?
Yeah, for me, the older patients, particularly those with comorbidities that involve cardiovascular disease, those are the ones where I'm avoiding ibrutinib now because we have head-to-head data comparing acalabrutinib with ibrutinib as well as head-to-head data of zanubrutinib versus ibrutinib. And to me, the takeaways from those head-to-head phase 3 studies are that particularly for patients with cardiovascular comorbidities, this next generation of covalent BTK inhibitors is better tolerated. I think there are still young, fit patients who can tolerate ibrutinib well, and it's once daily dosing, and there's a very long track record with the drug and a lot of experience. So, I think that's going to be an opportunity for those patients. And then, I think for the decision between acalabrutinib and zanubrutinib, we do have patients, for example, who suffer from headaches. That is a known risk with acalabrutinib, so that might be a patient you'd prioritize zanubrutinib for. We may have patients who have issues with hypertension, and it seems like maybe the rates are a little higher with zanubrutinib, so maybe we put that patient on acalabrutinib. And there's a variety of other kind of nuances between these two drugs that might push us one way or the other.
Yeah, absolutely. I think the other issue to bring up is the hypertension with ibrutinib happens sometimes very late, and have to watch out with patients for that and continue to monitor them carefully. I've seen the hypertension happen kind of years later, and so it kind of sneaks up on you. I have to be a little bit careful about that, and that's another patient population may want to change to a different BTK inhibitor.
Yeah, that's a great point.
Yeah. And then finally, how about the MAJIC trial as far as some discussions on that?
Yeah, so the MAJIC trial is one that I've been very involved with helping to co-develop along with Anthony Mato from Memorial Sloan Kettering and Jeff Sharman from Willamette Valley Cancer Institute. We've come together to try to really answer the question of what is the optimal venetoclax-based doublet for frontline CLL treatment across all comers, all ages, all genetic risk groups. And so this trial has not yet activated, but we hope will activate very soon. And there was a poster presented kind of summarizing the study design. And really just briefly, this is a comparison of venetoclax plus obinutuzumab, which is kind of the standard comparator arm, to a combination of acalabrutinib with venetoclax. And one of the things that's unique about this study is that both arms of the study have MRD-guided treatment duration, and that includes the control arm. So typically, I think as you know, the venetoclax plus obinutuzumab approved regimen is 1 year for all patients, regardless of what their MRD status is at the end of that year. And to sort of make this a more fair comparison for both arms, we're allowing a measurement of MRD at the end of the 1 year of venetoclax therapy. Those patients who are undetectable for MRD would stop treatment, and those who still have detectable MRD would go on to receive a second year of venetoclax-based therapy. But importantly, as I think we're moving toward more time-limited therapies in CLL, all patients in the MAJIC study will stop treatment after 2 years of venetoclax-based therapy, regardless of what their MRD status is at that point. And then the other unique aspect of the study is that we're utilizing the NGS-based approach, clonoSEQ, for our MRD testing. And this is allowing us to get down to a level consistently of 10 to the minus fifth detection rather than 10 to the minus fourth by flow, which has been traditionally used in trials. And we're hoping this will be allowing us to more accurately sort of risk stratify patients and identify those patients who really can safely discontinue therapy and enjoy a long progression-free survival. And of course, we'll look at a variety of other key secondary endpoints around safety and patient-reported outcomes. We're really considering any CLL patient who needs frontline treatment to be eligible for this study as long as they're a venetoclax candidate. I think the one situation might be sort of patients with significant renal dysfunction might not be great candidates for this study, but otherwise, we hope that this will be a broad eligibility. We'll recruit fairly quickly. And then the primary endpoint is going to look at the 3-year progression-free survival. And we expect that this is a non-inferiority study, so we expect to see kind of hopefully relatively similar rates of undetectable MRD and then eventually PFS at that short time point. But I think, over time, we'll see if there are differences that emerge. Is it worth it to use the BTK inhibitor early on, or is it better to save it for later? I think that's another key question that our study will help to address.
Yeah, I think using the clonoSEQ assay is a really important discussion point. I'm not really sure it's being used very much in the community now, even though it was used in the original venetoclax trials. But do you find it difficult to use or a problem at all to use the clonoSEQ assay?
We've found it very easy to send, and we have been sending it mostly just kind of for prognostic purposes in our patients on venetoclax-based regimens, particularly venetoclax obinutuzumab in the frontline setting. I think you're right that it's not being widely sent right now, particularly outside of academic medical centers, and I think that makes sense because so far we haven't really demonstrated a benefit for patients of using MRD-guided therapy, at least in any kind of definitive way in CLL. So that's why we're building this into our study to try to generate a large data set to show that actually it is feasible to get long remissions after an MRD-guided treatment discontinuation strategy. And we're just one of many different studies looking at this now in CLL, including some studies comparing MRD-guided based therapy to fixed duration therapy. And so, hopefully over the next few years, we'll accumulate enough data so that MRD will be very impactful in terms of therapy duration in patients with CLL. But I think the burden of proof really is on us as clinical investigators to demonstrate that it is useful before it'll be taken up widely.
Yeah, absolutely. So I think that's an important point that a lot of people are looking to these studies to find that information and to know if they should use it or not. That's a really great study, and about 10 years from now, we'll come back and talk about it again.
Exactly. Great.
So I'll move on to the mantle cell part now. And first of all, I'm just going to talk about, again, the BRUIN phase 1/2 study, which had a mantle cell component to that. And that was presented as a phase 1/2. So the phase 1 had pirtobrutinib at 25 to 300 milligram dosage range. And then the phase 2 went on to 200 milligrams per day on a 28-day cycle. And there were 134 mantle cell patients in this particular study, which is quite a large number. And they were looked at for, obviously, the PK, overall response, duration of response, and other important outcomes. So patients in this study had a wide range, but average age was about 70, which is fairly common for patients with mantle cell lymphoma as well. And they, for the most part, had classical mantle cell, but some blastoid or pleomorphic in about 20% of patients. The patients were fairly heavily pretreated. 90% had a prior BTK. Almost all of them had a prior anti-CD20. A lot of them had transplant and BTK inhibitors and even some CAR T cell therapy. So they were fairly heavily pretreated. And just like in CLL, the responses were very important, and I think very interesting in this very heavily treated population. So overall response rate was about 50% approximately, and about 25% complete remissions, which again would be very difficult in this heavily treated population. The efficacy in the BTK naive patients was actually overall response rate of about 82%, and so fairly high. The duration of response for this, the median follow-up for these patients was about 8 months, ongoing responses in about 60% of patients. Again, for these very heavily treated patients, I think these are actually really interesting and important results. And presumably when this is moved up closer to, kind of first, second, third line, the responses will be even higher. The safety, again, was very similar to the CLL patients, really very well tolerated, hardly any grade 3 or 4 toxicities. They did have a little bit of low-grade, grade 1 bruising, rash, arthralgia, kind of the usual BTK type symptoms, but really hardly any even grade 2 toxicities in that range. So very well tolerated. Also for hypertension, very well tolerated. So I think this, in addition to the CLL part, shows that the tolerability of pirtobrutinib is really excellent. It's very useful in patients that have already failed a different BTK inhibitor or failed multiple therapies. And I think obviously the next studies are trying to look at that in a little bit less heavily treated population. And I think we'll be able to show us again in mantle cell lymphoma some of these important outcomes and tolerability that we're looking for.
And I guess a couple questions come to mind. One is, I think it's likely that pirtobrutinib is going to get a label first in mantle cell lymphoma, even before CLL, potentially based on an accelerated approval. And if that were to happen, how would it work in your practice? Which patients would you consider for pirtobrutinib now?
Yeah, I think that's gonna be tough because then you have so many choices in mantle cell. We already have 3 approved BTKs, and now this would be the 4th. So I think that, again, looking at the toxicity profile for the patients, trying to see what their premorbid conditions are as far as hypertension or atrial fibrillation or, clotting issues or problems with bleeding issues would be one thing to look at. For the patients who have blastic mantle cell or that we know have TP53 abnormalities, it might be that we want to look at some of these types of pirtobrutinib as a treatment to improve those outcomes, but that, of course, is not known yet. We don't have enough patients with those abnormalities. So I think there's a lot yet to be answered, but hopefully we'll be able to answer that in future studies.
Great. And then, I guess as we look to the future of pirtobrutinib and mantle cell lymphoma, are there particular combinations that you're excited about potentially being explored in future studies?
Yeah, I think definitely looking at pirtobrutinib with other anti-CD20 antibodies, obviously, because they work so well in mantle cell lymphoma as well. And then trying to look at even long-term outcomes, perhaps after transplant, and using BTK inhibitors plus or minus CD20 antibodies. I think we're going to see all different kinds of combinations, both upfront and in a relapse setting, and to be able to improve the outcome for patients with mantle cell, because unfortunately they do relapse again and again, just like the CLL patients, and we need multiple therapies for those patients.
So that was a great discussion of the phase 1/2 BRUIN study, but now pirtobrutinib is moving into later stage trials, including a trial called BRUIN MCL 321. So Dr. Vose, can you please tell us a little bit more about this trial and what you think of it?
Yeah, so this is a very large phase 3 trial of approximately 500 patients and a one-to-one randomization of pirtobrutinib versus choice of the other BTK inhibitors, ibrutinib, acalabrutinib, or zanubrutinib. And this is for patients with MCL that have been previously treated but have not received a prior BTK inhibitor. So basically, the first BTK inhibitor for this patient population. And this is a very large international study, very important study for these patients to see if pirtobrutinib is better as far as outcomes, toxicity, some of the other things. And then, of course, in looking at the mutations of MCL to see if there's a particular patient population that is better for pirtobrutinib. So this just started, and again, it's going to be a long time before we get the answers to this, but I think it's a really important, very large 500-patient trial. We'll be looking down the road for these answers.
And do you think they're looking at the right endpoints on this trial? Is it going to give us meaningful data?
It is. They're looking obviously for response rates and for progression-free survival, overall survival. Probably it's going to be unlikely, at least in the short term, there's going to be an overall survival advantage. These patients would likely need to be followed for a very long time to see that. But certainly, I think response rates and progression-free survival is a very important endpoint. And then, of course, tolerability as well. And then looking at time of relapse, if they do get mutations and that sort of thing as well in the study. So yes, I think it's a very good endpoints, very important study, and I'll be anxious to see the results.
Yeah, certainly I will as well. And, I think to me also the safety comparison is going to be very interesting since we don't have other randomized data comparing pirtobrutinib to other BTK inhibitors. And, I wonder also whether we'll extrapolate from this mantle cell study into CLL if we do see meaningful safety differences between the different drugs.
Right. And also in mantle cell, the distribution of the lymphoma is a little bit unusual. Sometimes there's, CNS involvement or privileged site involvement. So I think that'll be interesting to look at as well and see the number of relapses in kind of unusual locations.
Yeah, for sure. And then, the last study that we wanted to talk about is the BRIDGE study, which was looking at zanubrutinib-based induction and maintenance in the younger fit population of untreated mantle cell lymphoma. Dr. Vose, can you tell us a little bit more about this study?
Yeah, so the BRIDGE study is an interesting study. It's started in a very small number of patients. So this is a study of patients that are adult mantle cell patients, kind of usual characteristics with no CNS involvement and no prior stem cell transplant. So they receive alternating induction with R-CHOP times 3 cycles, alternating with R-DHAP or similar type regimens every 21 days. And they also receive zanubrutinib on cycles 1, 3, and 5 with the R-CHOP regimen. Then if the patients have a greater than or equal to a partial response, they can go on to autologous stem cell transplant as kind of per standard of care. And then they receive, as part of the study, zanubrutinib maintenance for 2 years after the transplant. So the primary endpoint is, in fact, MRD negativity, and secondary endpoints are progression-free survival, overall survival. There was just a very small initial subset of this that was presented at the Pan Pacific Conference with 7 patients. Median age is about 52, mostly advanced stage disease, as would be expected. They did have peripheral blood and bone marrow involvement in all the patients, and a lot of GI and other involvement that's typical for mantle cell. And of course, this is very short follow-up, median of only 35 weeks, but they were able to complete the MRD testing in the majority of those patients. And they found that 5 of the 7 had completed greater than 1 MRD test, so very short follow-up, and that all achieved MRD negativity that have been tested so far in the peripheral blood and bone marrow. 1 patient had gone on to the stem cell transplant, so this is very early in this testing. As far as safety, they also looked, of course, at the typical safety analysis and found that the majority of patients really tolerated the zanubrutinib very well without any major side effects or complications. Grade 3/4 neutropenia was only found in 2 out of the 7 patients with the zanubrutinib. So, I think this is very early, obviously, but really interesting analysis and an interesting design with the major response of looking at MRD negativity and, of course, clinical response. And I think this is something that we're going to see a lot more of, the different combinations of chemotherapy, immunotherapy, and BTK inhibitors together.
Yeah, for sure. And I think one of the things that seems appealing to me about this design is that it's a time-limited amount of BTK inhibitor after that 2 years of maintenance. Is that correct, or do they continue on until progressive disease?
Yeah, the study design is a 2-year time-limited BTK inhibitor, which, again, I think is an important aspect because, as we all know, unfortunately, the BTK inhibitors are very expensive, and to have a unlimited number of years on these sometimes is very difficult for patients as well as for toxicity purposes. So I think that the time-limited aspect is really important for sure.
Yeah, I agree. Especially then also might open up using the BTK inhibitor again as another line of therapy if they have several years of remission. So I think there's lots of potential advantages there.
Yeah, to kind of mix and match our different treatments, to have time off therapy may mean that the lymphoma becomes sensitive again to that particular agent or a similar agent. So I think particularly in the BTK inhibitors, that's an important concept.
Yeah, I fully agree.
Yeah. Well, thank you very much. I think that was a very interesting discussion, and look forward to seeing these publications.
Great. Thanks so much, Dr. Vose. I agree. And a lot of exciting data. Thanks so much.
Thank you.
Thank you very much, Dr. Vose and Dr. Davids, and thanks to you, the listeners, for joining us. As a reminder, to view the full program, a global perspective on emerging BTK inhibitor therapy data for relapsed refractory CLL and MCL in 2022, and to access additional resources associated with this program from the Clinical Care Options website, please click on the link in the show notes. As always, thanks for listening.